I just wondered how you felt about the criticism you got at DMEC, Bill, and whether it was founded. Clearly the MSF, the 360-degree appraisal in surgical training, provides ample opportunity for a multidisciplinary view of a trainee's practice. During the early years of training, it's perfectly okay for workplace-based assessments to be performed by non-medical practitioners when they have the competence that is being assessed. But regarding the current general surgical training submission, which is where surgery for the first time is saying the multi-consultant review is the new assessment that we want to introduce into training, how realistic is it that non-consultant trainers are going to be able to contribute to that exercise? Not other areas of assessment, but that exercise.
We've already got some of it in terms of the fact that we've had this question before about non-consultants such as staff grade, associate specialists, doing assessments of technical competence. And JCST has taken the view that as long as those individuals can demonstrate they've been trained in the way in which you should do an assessment of a learner, that's perfectly acceptable. In a way, some of what we've heard from the extended workforce presentation, there will be individuals there who actually are more skilled once this program has got going than those who are in a training position. So in other words, they could quite easily contribute to that. And it's this point that I think there's a far greater, oh good, he's here. There's a far greater emphasis on the totality of an individual's performance, that we've got to be fairly careful we don't get locked into the silos we have got locked into. And therefore the input into an individual's behaviour and performance, and they can be very closely interlinked, I think does mean that it will be non-medically qualified people, perfectly appropriate to make comment.
Bill, to ask you a question really that we talked about earlier, how do you think we'll be able to accelerate or decelerate a trainee during their training within the structures that we have now?
If you can demonstrate as a trainee that you are progressing and achieving the competencies that are defined in the curriculum, I think probably it will come in the second year. By the time you've done your first year's ARCP, you will have demonstrated you've got your competencies, then you get into the second year, and you may well be ahead of the curve by then. And that's why I think by having these much more regular interactions, that the educational supervisor will be able to recognise whether or not someone's making it or they're not. It's probably easier to pick up the flyers and the less well-performing ones. And that's why I think you will find that probably, I would like to think, that by the time you get into by 18 months in, you will probably know if they're going to if they're going fast, and therefore can begin to draw down on ST3 competencies. The other end of the spectrum is I think is a more difficult one. I think that, again, by having a very much more regular discussion to say, well, are you achieving what you feel you should be doing? We recognise you're actually struggling with some of these technical things. Perhaps a bit more time doing some simulation might be helpful. And if they continue not to make the grade, then I think we do have a bit of a problem as to what we do with those individuals. And when I think that the terminology that we've now got, actually that's within the GPC descriptors, will be actually quite useful to draw down on, to make comments about what an individual is doing. Because within GPC, you've still got professional skills and knowledge. So I think there's terminology that we can use there that's consistent.
And to put meat on those bones, when you say more frequent meetings with their educational supervisor, are we monthly, Is that the sort of frequency with
I
which you're
think
thinking?
so. Yeah, I mean, I think, you know, we've said the amount of time. One of the problems when we were looking at the criteria for the posts was that in job plans for the trainers, they were given the adequate amount of time that we've asked for. When we originally talked about 0.5, or we've gone down to 0.25, which I think was a more practical way of doing it. But by having that regular interaction that's in the timetable, then that allows those conversations to be had to say, perhaps you're not making it, or perhaps we've got to concentrate on something else at this stage, rather than going down that sort of direction. So it's by that much more regular input, I think we'll get that information.
David Wilkinson, I think, wanted to come in.
It's just a comment, perhaps, rather than a question. I think part of the difficulty is that the whole system is rather set in the A bit of the ARCP in terms of managing progression. Trainees, the service, trainers, schools tend to think, and no criticism, just the way it is, that you do a year and then you go and get a sign-off. There's no way of accelerating. You might go too slowly, but generally you get that year signed off and then you move to another year, and generally you go somewhere else for that. And then in an uncoupled program, you then, as we all know, there's an opportunity here to take a slightly different approach to it. And with a professionalised trainer who's fully cognizant of the curriculum, knows full well what the trainee's ability is, those trainees may vary at the moment that they start, from some who have no experience at all in surgery and come straight from F2, and others who may have spent time in surgery in either service posts or other training posts, either overseas or in the UK. They may be quite different, and the level at which they're going to be at and the speed at which they will progress will vary from day one. And the regular meeting between a professionalised trainer, that individual, ought to manage that individual's exposure, support and supervision as required for their individual need. And then rather than at ARCP simply deciding whether you've met a one-year set of competences, you make a judgment on the competences that individual has achieved against the curriculum, without really getting bogged down in the fact that it's a year or 2 or 3. And therefore they may very well have progressed whilst in that program beyond what you've expected trainees normally to do, or on the other hand they may not have done. But that would be an individual measurement, an individual assessment of their progress. And so,
I think that answers the
and
first
the
question.
top question, the answer is probably yes then, that might be helpful. And in the bottom question, guiding the use of simulation as required for the trainee's individual need, yeah, I think we need to do that. Some trainees, when they start, may be at the level where they need to go on a basic surgical skills course and mastering basic suturing and tying knots. You may have trainees starting in the pilot who've already done all that and are really quite good at it, and their level needs to be higher on. And that judgment needs to be made early on by a trainer who's familiar with the curriculum, who's in a position to have the time to watch the trainee and see what they can do and how they perform and what they need to do next.
David, while you've got the microphone, because this issue of CIP is not an IST-only issue, it's going to apply to the whole of medicine as far as I can tell, the whole of medical training. Does HE have any plans to educate, train the rest of the consultant workforce in other specialties?
I'm sure we do. But yes, that process of moving to these curricula over the next, guided by the regulator, over the next,
3 years.
Yeah, no, it's soon to be 2. But 3 years. The thing has to run in parallel. We have to have trainer engagement, trainer training, trainee understanding of, and this is all about what happens to them, and system understanding of what this is. Yeah.
The Academy, Joint Academy Training Forum has set the task of a series of standards about how outcome-based training should be looked into, which includes the GPCs, and that will be then given to the colleges to put in place as appropriate for their specialty. And that's something that requires the college faculties to develop with guidance from the Academy. That's in process.
Okay.
We're not done it.
middle question, and then we'll do for lunch, which is what happens when the CIPs conflict with the impression gained from the WBAs?
I think actually, thinking about that one, if you think there's a problem, you can use the WBAs as the evidence to show whether or not there's a problem. So the CIP issue is very much a global assessment using evidence from the WBAs. In the pilot to start with, the evidence going to the ARCP will be based upon the WBAs as it currently is. So I think in a way, for the purposes of the pilot, yes, we want to consider looking at CIPs, but they should be a guide to a potential problem or potential acceleration. And that will then be supported by this traditional approach with the WBAs. It will change once all the other curricula have got the outcomes-based approach embedded.
Okay. Thank you. I'm going to stop it there because we're going to take lunch. Craig has arrived.